We'll touch here on some of the other aneurysms that I wasn't really able to fit nicely into the other sections. So the first four we're going to talk about are aortic dissection, which is really just a dissecting thoracic aortic aneurysm. Two types of thoracic aortic aneurysms, either dissecting or non-dissecting. We're going to talk about the dissecting thoracic aortic aneurysm. This is probably the most important thing we're going to talk about, so I want to discuss it first. Then we'll talk about the popliteal aneurysm, which is probably the second most important thing we'll talk about, and then the splenic artery aneurysm and iliac artery aneurysm. As far as importance, I mean likelihood they'll come up on the USMLE. Cerebral aneurysm is more of a domain of neurosurgery, but we can't have a discussion on aneurysms without at least bringing up the cerebral artery aneurysms. So I do want to talk about that. That's also another important one. But it's really not so much a domain of vascular surgery as much as it is neurosurgery. So aortic dissection can be classified two different ways, DeBakey or Stanford. I like to use the DeBakey classification because it's a little more specific. So there's three different parts of the thoracic aorta that we're keeping in mind. That's going to be the ascending thoracic aorta, which is this part here, then the arch of the aorta, and then the descending aorta. So with DeBakey 1, you've got the aorta affected both at the ascending and the descending portion. This is the most common aortic dissection. It's about 60%. So ascending and descending. DeBakey type 2 is the least common, about 10 to 15% of patients. It only affects the ascending aorta. And then DeBakey type 3 is only affecting the descending aorta. So the aortic dissection is an aneurysm of the aorta proximal to the diaphragm. As you know, once the aorta crosses the diaphragm, it becomes the abdominal aorta. I talked about abdominal aortic aneurysms in a different section. Risk factors for aortic dissection include poorly controlled hypertension, atherosclerosis, connective tissue diseases. Some other things are male gender, 2 to 3 times more likely to get an aortic dissection if you're male than if you're a female. Some of the congenital heart diseases put you at risk for aortic dissection. Third trimester of pregnancy, you're more likely to get an aortic dissection. And then some other things would include Turner's disorder, which is the X0 girls, and then cocaine use puts you at risk for aortic dissection as well. Okay, symptoms, classically, and I would expect on the USMLE you'll be told this, it's severe chest pain, which is classically described as tearing, ripping, and it radiates to the back, but it can also radiate up to the upper shoulder, to the jaw, down the arm, but usually they tell you it radiates to the back. You can also see unequal pulses in the upper extremities, and that's just simply because these 3 arteries coming off the arch of the aorta are your innominate, right innominate, your left common carotid, and your left subclavian. And so if you have any kind of unequal flow to these arteries, then you can have unequal pressures on either side, and that's going to be palpable. Other things that you can see is a new diastolic murmur, or I guess you'd hear that. So a new diastolic murmur would be a murmur of aortic regurgitation, which would be a diastolic murmur at the right upper sternal border. And that's because you're getting, you've got blood that's sticking around in the ascending aorta, and that's going to trickle back down during diastole. And then another thing that you can see is hoarseness, and that's because of the widened mediastinum. It can impede upon the left recurrent laryngeal nerve. Diagnosis. Best initial diagnostic test is an EKG. Why? That's not going to help you diagnose aortic dissection, but when you have a patient with chest pain, the first thing we always have to do is rule out an MI. So we're going to get an EKG. We're going to look for any kind of ST elevation or ST depression, any kind of abnormalities there. We're also going to get cardiac enzymes and probably also a chest x-ray. All of these things should come back normal, well, except for the chest x-ray. But your EKG and enzymes should come back normal. That's going to rule out the MI. Your chest x-ray will probably show a widened mediastinum, but that only occurs in about 75% of patients with aortic dissection. So you can't necessarily rely on a chest x-ray. The best test to get to diagnose aortic dissection is either a spiral CT with contrast or a transesophageal echocardiogram. I saw two different sources. Some say spiral CT is the best, some say transesophageal echocardiogram is the best, so I don't expect you'll be asked to choose between the two, but just know it's one of those. I would go with the transesophageal echocardiogram if I had to choose between the two, but one of those, you'll probably only get one of those to choose from. And then there are other tests that are used. MRI may be used, but these are the two best. Okay, the treatment. What do we do? It's rather nuanced, but the initial thing you need to do, and what I imagine you're going to be asked about as far as treatment, is of course your ABCs. Make sure that the patient has a stable airway. Make sure that you've got large bore IVs inserted, so in case you need to replace fluids. And then administer labetalol, then nitroprusside. What we want to do here is lower the blood pressure so that we reduce the shear force, because it's the shear force that's aggravating the dissection and worsening it. Now, surgically, what's our definitive therapy? I don't think you're going to be asked about that. But whether or not we intervene surgically depends on a lot of factors. Usually the rule of thumb is if it's affecting the descending aorta, we don't treat them surgically unless they're unstable. We just treat their hypertension and observe them in an ICU setting. But if it's a dissection of the ascending aorta, or if it's an unstable patient, we're going to repair them surgically. So here's a widened mediastinum, and this is secondary to aortic dissection. So you see here, this is quite apparent. And here's another one. So widened mediastinum. That'd be on chest x-ray. Now the aortic dissection on CT, what you see is a false and a true lumen. So you've got a separation. This layer here is separating your aorta, and so you have luminal separation here, false lumen and true lumen. So this little line here is what's telling you that it's aortic dissection. There's another one. Okay, so moving on. Popliteal artery aneurysm is an aneurysm of the popliteal artery, and it is the second most common aneurysm overall, only second to the abdominal aortic aneurysm. Risk factors are typical for most aneurysms: atherosclerosis, hypertension, hyperlipidemia, smoking, diabetes, etc. Usually these patients are asymptomatic. This is just diagnosed on physical examination, and what you're going to note is strong popliteal pulses, and this is quite common. So if a patient does have risk factors for atherosclerosis, this is something that you should be checking for, because this is a silent disease until there's a rupture. So strong popliteal pulses are common in asymptomatic patients. If there is a rupture, then what happens is ultimately you're going to get acute lower extremity ischemia. So for diagnosis, once you've felt these strong popliteal pulses and you have an index of suspicion, best initial diagnostic step is going to be a duplex ultrasound over the popliteal artery. If you get a positive test, then you're going to follow it up with angiography, and that's for surgical planning. The treatment here is going to be endovascular or open repair. Endovascular repair is coming into favor just because it's a little less invasive. You'll just place a stent in there, and that will block off the flow to the aneurysm pouch, so reduce the risk of rupture. You can also do it via open repair, but endovascular repair is coming into more favor. I don't expect you'll be asked to choose between the two. So one of the things that I want to bring up here as a clinical note, 50% of popliteal aneurysms are bilateral, so most patients will have aneurysms on both sides. And then about 25 to 33% of patients with a popliteal artery aneurysm also have abdominal aortic aneurysms as well. So this is a red flag for something that's even worse. So I wanted to show you this here from Elsevier. This is the coincidence of other aneurysms with popliteal artery aneurysms. So you see about a 53% coincidence on the contralateral side, about 55% coincidence. This is another even higher number than I saw earlier. 55% coincidence with the abdominal aorta. So you've got to be checking out for these things. Splenic artery aneurysms is an aneurysm of the splenic artery. It's the third most common abdominal aneurysm, and this one stands out because it's 4 times more common in women. So some notable risk factors include portal hypertension, and of course the reason for that is, if you remember, where does the splenic artery come from? It comes off of your celiac trunk. And your celiac trunk also gives rise to your common hepatic artery, which will eventually go in as the proper hepatic artery. And so if you have portal hypertension, it's going to reflect that hypertension backwards. And so that will ultimately affect the splenic artery. And this is another reason why you get your varices, because of all that pressure moving backwards. But you'll have that reflected pressure, and it reflects back to your splenic artery. Another thing that increases your risk is multiple pregnancies and pregnancy in the 3rd trimester. And again, this is just due to reflected pressure. Splenic artery aneurysms, and this is kind of an OBGYN note, but it should always be considered in any pregnant woman with sudden collapse and shock, especially a pregnant woman who's later on in her pregnancy, 7, 8, 9 months. The vast majority of patients who have splenic artery aneurysms are asymptomatic, and they're discovered just coincidentally with a CT. However, the ones who aren't asymptomatic, they often present after a rupture, and so that's a big problem. And so this does actually carry with it a higher mortality rate. Let's see where my numbers here. About 5% about 5% of patients with splenic artery aneurysms present with hypovolemic shock, and the mortality of rupture is about 25%. And if the patient is pregnant, that mortality rate goes up to 70%. So this is a big deal. If we do see a splenic artery aneurysm, coincidentally, most of the time we're going to want to treat it. So symptom-wise, if you do have a rupture, if it's a smaller rupture, it may present just as acute left upper quadrant abdominal pain. And I want you to note here, left upper quadrant, you don't get specific left upper quadrant pain that often. Left lower quadrant, you get a lot. Right lower quadrant, you get a lot, like appendicitis. Right upper quadrant, you get a lot, like a gallbladder pain. So left upper quadrant is not a lot goes on there. So if a patient does have acute left upper quadrant pain, then this is definitely going to be on your differential, especially if they have risk factors. Nausea and vomiting can happen, and that's just because the abdominal pain is so bad, and then ultimately shock due to blood loss. What do we do for diagnosis? Well, because this is usually coincidental, you see it as on the CT. Otherwise, the best initial test to do is sonography, and you're just looking for blood loss into the abdominal space. So that would be the best initial test to do. More accurate would be CT. So if the patient is unstable, then to diagnose them, you're going to want to do sonography. You're not going to want to roll them in for a CT. Treatment. We'll want to stabilize the patient if necessary, so make sure that you've got your lines going with fluids. Make sure you got a stable airway. Definitive treatment can be done either via endovascular or open approach. Of course, if it's a rupture, you're going to have to do it via open approach. The treatment indications include rupture, if there's any kind of present symptoms. If it's a woman of childbearing age, then you're going to want to make sure that she is treated before she ever possibly gets pregnant again, because that's going to put her at a higher risk for rupture, and if the aneurysm is more than 2 centimeters. The iliac artery aneurysm can be noted on either abdominal or rectal exam as a pulsatile mass. The iliac artery aneurysm almost always coincides with abdominal aortic aneurysms. They're usually extensions of the abdominal aortic aneurysm, so this should tip your head off to abdominal aortic aneurysms. Usually these are asymptomatic, just like abdominal aortic aneurysms, although sometimes you may have coinciding abdominal or groin pain, or there might be a mass present if it's big enough. Best initial diagnostic test, if you feel a pulsatile mass in the groin or on rectal exam, would be to get a sonogram. That will tell you how large it is, and then of course eventually you're going to, if you're going to do repair, you're going to want to get an arteriogram, and that's going to help you plot exactly what surgical approach you're going to take. The management is similar to abdominal aortic aneurysm. If it's not big enough, then you can just get by with minimizing risk factors. However, if surgical repair is necessary, then usually this is done via stenting or open repair if it's emergent. So 3 centimeters is usually the cutoff point. But the big thing I want you to take from this is that the iliac artery aneurysms tend to coincide with abdominal aortic aneurysms, which I discussed in another section. Okay, so cerebral artery aneurysms are aneurysms of any of the cerebral arteries which come off of the internal carotid artery after it splits off into the middle cerebral artery and the anterior cerebral artery. The most common place to have cerebral aneurysms are at bifurcations. Of those, the most common place would be where the anterior cerebral artery gives rise to the anterior communicating artery, but you also commonly see it where the internal carotid artery gives rise to the ACA and MCA. These are also asymptomatic until rupture. 33% of patients with cerebral aneurysms will die before reaching the hospital. Risk factors include hypertension, smoking, alcohol use, cocaine use, and then some big ones that you're going to be expected to remember for the USMLE, especially autosomal dominant polycystic kidney disease, ADPKD. And that's the adult version. And then fibromuscular dysplasia is another thing that increases your risk pretty much for all aneurysms. What are the symptoms we see? Well, if it's a ruptured cerebral aneurysm, you're going to get your thunderclap headache, which shows you that it's a subarachnoid hemorrhage. That's always associated with subarachnoid hemorrhage. Typically, patients describe that as the worst headache they've ever had. Nuchal rigidity, neck pain, facial pain, altered mental status, seizures, visual changes like diplopia or blurred vision, and these are acute. So this isn't something that started 2 days ago. This is usually something that started today, recently. What do we do for diagnosis? If you have a patient with a thunderclap headache, with the worst headache they've ever had, the first thing you're going to do is get a CT. And if the CT is positive, and I'll show you what that positive CT looks like, if it's positive for a subarachnoid hemorrhage, then you're concerned about cerebral aneurysm. So what do we do for treatment? Ensure the patient is stable, as usual, maintain airway and fluids. You're going to want to control the hypertension if there is any, so calcium channel blockers, and then of course seizure prophylaxis, because these patients are at risk for seizures once they get bleeding into the intracranial space. So we'll do that by prophylactically administering benzodiazepines. Surgery involves clipping of the aneurysm, and that's going to be neurosurgery. So what I wanted to point out here was how the CT looks, and this is your classic star sign on CT. So this shows you that you've got bleeding into the subarachnoid space. So here's another one that's even more apparent. All right, and if you have any questions, feel free to let me know.